back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy. When this video is a continuation of the express revision course for oral surgery. And before we get started, make sure you subscribe to the channel and hit on the bell icon so that you don't miss any of our exciting videos. And you can also check out the channel and playlist. You'll find more exciting and interesting videos like this. And if you are interested in the notes of this particular video lecture, you can check out the link provided in the description box below. And also guys, check out our website www.x2.com for more interesting notes. So let's get started with the today's topic. Now, what happens when a person comes to the emergency department or to your clinic with a fracture? So with the trauma. So the first thing, if you have observed, like in general, if a person has undergone fracture, when you go to the doctor, he does the plaster for you, right? So this is a kind of a reduction, which is a closed reduction. So we will be talking about in today's video, what do we do after we get over with the emergency part. So up till now, we have studied that in case if there is a maxillofacial trauma, say with the accident or any trauma which is involved, afterwards, first thing which we have to maintain when the patient comes to the emergency department is checking on ABC, which is the airway maintenance, breathing and circulation. So this is the kind of a emergency treatment which you do after the maxillofacial trauma, which we have covered in the previous part of the video. So after you have maintained the airway, breathing, circulation, everything is maintained. Now there are two things which you can do. You can either go for the open reduction, or you can go for the closed reduction. Now, what do we mean by this? Now that we know patient is out of danger, so now we need to reduce the fracture, right? This is therefore that is the term which is used for reduction. That means we are reducing the fracture. Say suppose this is the bone, right? And this bone has undergone, after a trauma, undergone into the fracture. So say this is the fracture line which we see in a radiograph. Now what we want to do is we want to treat this fracture. So what you have seen usually doing is approximating these two fragments together and then put a plaster. This is what, when there is a normal injury in the limbs, extremities, anywhere, if you have seen that doctor is putting the plaster. So that is a closed reduction. That means, see, open reduction guys, open means opening up, like opening up the bone. So we elevate the flap, we see everything which is opened to us, like it is elevating the flap and you can see the bone. So that is like opening reduction. So we are first of all removing the flap, then we have a visualization over the bone, and then we are going to approximate both of these bones together. This is the open reduction. That means open reduction is doing the surgery. So what we do, if in the open reduction guys, say these are the two fracture. Now we have to make one more diagram over here. Say suppose this was the fracture. So and both of these fragments are apart. Say, see guys, what happens, mandible is a single bone. Now what happens when there is a fracture of the mandible? So there is displacement. Say suppose there is a fracture here. So here in the lingual portion we have the muscle attachment. In the condyle also here we have the muscle attachment. So these muscle attachment are going to take this part of the fracture on one side because attachment is here. So the fracture is going to be like this. If there is fracture in the anterior region, then because of the genioglossus, geniohyoid muscle, all these muscles which are associated with a genial attachment in the anterior and lingual part of the mandible, so they are going to take the mandible back. So that is the reason that we call it, there is a drop or step deformity, all these cases all these terms which we say. Now what happens, say suppose you cannot see, putting a plaster in a mouth is like doing an intermaxillary fixation. So what we do is we approximate the teeth, we make the teeth in contact like how it was before trauma. If the person was having, or the child was having, a class 1 malocclusion, class 1 molar relationship, then we get into the class 1 relationship. A person was having a class 2. Basically we are taking both the teeth together, get in centric relation, then occlude these teeth and then fix these teeth. So say suppose here we have placed the arch wires, which we will be covering in the intermaxillary fixation, and we take a wire and we are going to attach the maxillary teeth to the mandibular teeth and fix it. That is why we call it intermaxillary fixation. That means we are fixing the maxillary and the mandibular teeth together. So that is what we do in closed reduction, right? So that is a kind of plaster which we do in the in dentistry, because we want that no movement should take place. What if there is a displaced fracture, say? What if the fracture fragments, whenever you are closing it together, it is again opening up, again they are coming back into its, because of the functional movement, whenever the patient is opening the mouth, the fracture segments are getting apart. So in that case, what you need to do, if the patient is undergone for any emergency surgery, say if you have done like nasotracheal intubation, or if you are doing any surgery to prevent this emergency, so in that case, that moment only, because since you have opened the flap, so immediately you are going to do the reduction. So reduction is basically taking these fractured segments together. This is what do we call reduction. That means we are taking all these fragments together where they belong, and if we are doing it surgically, we call it open reduction. And we can, if you are doing any emergency surgeries, when a patient has come to ER, emergency department, and you have to do the surgery to maintain the airway, breathing or circulation, any of it, that moment itself, the maxillofacial surgeon is going to reduce the fracture segment. That means taking the fracture segments back, and then we put the plates. If we are putting plates or screws, so say suppose if you are taking all these fracture fragments back together, and once the person opens the mouth, both of these fragments are again apart. So because of this functional movement, these fracture fragments, they are not together, they are getting aparted. So in that case, what you need to do, guys, is you need to put a plate over here. So we need to put a plate, and in the plate there are holes for the screw, and then we place the screws, and therefore this is like kind of a fixed, we have fixed both these fracture segments. So that is known as the fixation, which we will also cover. So we are putting the plates, or if you are putting the screws, in order to maintain or in order to do the reduction, we call it the open reduction. Now how does this healing happens? See, in the closed reduction, you are not doing any surgery, you are just approximating the maxillary mandibular teeth in a contact relationship, and then you are going to attach both of these with the help of wires like brackets. If you have seen ortho brackets like that, we have arch wires. So these arch wires has space for the arch, for the wire to pass, and then we tightly close the maxillary and mandibular teeth. Now the question is, most of the times the student asks me, ma'am, then how will the person will eat? So guys, what we do is we put the Ryle's tube for like all the liquid drinks. The person will be on liquid diet for like 4 to 6 weeks during this time. So basically for a month the person is going to be on a liquid diet. Sometimes what happens, the person like immediately wants to go to work, or not at least work from home or anything, or if the person wants to maintain the diet, so they ask to do the open reduction for you. So that the open reduction, guys, you are doing a surgery, and like after the next day, or maybe in 3 to 4 days or so, the person can eat. But before you are treating the fracture, you have to manage the soft tissues. So that is the first priority. At the first, what you do is you manage the soft tissue, then you go for the hard tissue. Once the swelling is subsided, then you go for all the surgery, or you do whatever you want to do. So guys, what happens, this healing process will induce the bone formation. So how does the healing happens? It is different if we are doing a closed reduction. It is different if we are reducing the fracture with open reduction. Say we are doing the fixation. So fixation is basically putting either the plates or the screws and then placing both of the fracture segments together. So guys, this closed reduction, that means there is no surgery. Reduction means approximating both the fracture segments. Closed reduction means no surgery, we are not opening up. So we are just putting or approximating the maxillary mandibular teeth together, and then we are going to fix this. We call it intermaxillary fixation. So in the closed reduction, what we do, we fix the maxillary mandibular teeth for like 4 to 6 weeks of time. The person, sometimes there is a like escape or vent hole which is provided for the straw to like put between the teeth, so that the person can eat or drink properly. So in the closed reduction, there is secondary healing which occurs. Say suppose this was the fracture segment, guys. First of all, this was the bone. Now what happens, because of the fracture in the bone, we see that the two fracture segments, because of the fracture. So now what happens in the bone, guys, there were this blood vessels, right? So all these blood vessels, they get ruptured during the fracture. So there is a rupturing of these blood vessels, and because of that, there is like, because of the rupture of the blood vessels, the blood start accumulating. So here the blood start accumulating because of this rupture of blood vessels, and there is the hematoma which is formed, which causes the swelling after the fracture. Now you have seen almost all the times that we see that fracture is associated with swelling. So sometimes even after injury, and if you are not sure if the person has fractured, we look for the swelling. If there is swelling, then we suspect that the person might be having a fracture which is involved with this. So this phase is we call the hematoma formation after the fracture, right? First of all, there is accumulation of the blood. Now with this blood, there is like lot of tissue destruction because of the inflammation. So after this blood, we have got the inflammatory cells. So the next phase is the inflammation phase, which is an acute phase, so which is like for up till 1 week. So all the macrophages, cytokines, all the platelet derived growth factor, they start accumulating in that area. Now guys, what happens after 2 to 3 weeks, there are new blood capillaries which are formed and which fills. Now here there are new capillaries which are formed, right, because of the growth factors and all. So the new capillaries which are formed, we call it the soft callus, which is like 2 to 3 weeks. Basically it is meshwork of the granulation tissue, meshwork from the granulation tissues because of the inflammation process. So the mesenchymal cells, they start proliferating and differentiating. Now we have got fibroblast, all the blast cells which are going to form the normal bone. So we have fibroblast, odontoblast, osteoblast, not odontoblast, because odontoblast is associated with the formation of the teeth. So we are talking about bone. So we have osteoblast, chondroblast, fibroblast, all these blasts. And after few weeks, we see this mass has become hardened. So we call it the hard callus formation, or you can say the bony callus, any of it. So this is the process wherein the bone formation takes place, right? So bone formation takes place. Now it can be in two ways, either intramembranous ossification or endochondral bone formation. So after this, there is a bone remodeling, and the woven bone get converted to the cancellous bone. So guys, there is inflammation, repair and remodeling. Basically, if I want to summarize it up with the secondary healing process. Secondary healing process, this process is we see in the closed reduction, and we see almost 3 stages: inflammation, repair and remodeling. Now this is when there is no displacement of the fracture, right? When the fracture segments are in the same position, no muscle pulling. This type of fracture, we call it the undisplaced fracture. So when the fracture is not displaced, right, then we go for the closed reduction. But what if the fracture segments gets parted after the fracture? So then we have to go for the plates or the screws. We call it the open fixation, right? I mean open reduction. Open reduction, we are going to do the fixation. Either you can put the plates or you can put the screws, any of it. So there is direct healing in with it with this which is associated with the internal fixation. So we see that there is a primary healing. Now this is the difference between the healing process of open reduction and closed reduction. Closed reduction, we have seen the natural healing process, which is the secondary reduction, secondary healing. But in the open reduction, wherein we are going to wherein we are going to open the fracture site and we are going to see the bone, we are going to take all these fragments back into position and putting a plate or putting up screws is what do we call the internal fixation. And in the internal fixation, we see that there is a direct healing which takes place in the bone. So we have two kinds of open reduction. One is the gap healing, another one is the contact healing. So in the gap healing, guys, new capillaries and the progenitor cells, basically the fibroblast, osteoblast and the chondroblast, they grow in the edge of the fracture ends and they fill up the gap. So we have got narrow gaps or the wider gaps. If there are narrow gaps between the two fracture segments, then there is a direct laydown of the lamellar bone. But if there are wider gaps, then first woven bone will form like the closed reduction, and then the lamellar bone will form after the bone remodeling. And in the contact healing, there is no stage, there is direct the lamellar bone which is formed. I think that you guys are getting the differences between the open reduction and the closed reduction. So let's have a look at the differences. Closed reduction, guys, always remember, as the name suggests, close, that means the site is closed. We have not opened the fracture site. If we open the fracture site, we make the surgical incision and see whatever is there, take the fracture fragments back into its place and put a plate or screw, we call the open reduction. The closed reduction is wherein the fracture segments are not displaced. That means the bone is where it was previously, but there is a fracture. That is the closed reduction. In that we do the intermaxillary fixation. So what are the advantage of closed reduction? We do not have to go for surgery. It is a conservative procedure. So many times the people are afraid of surgery. So they are like, no doctor, you treat us the way it is. I do not want to go for any kind of surgery or something. So no surgical complication is involved. And if the person is having any medical condition in wherein the person like can be at a risk of some medical conditions, say bleeding disorder and all, wherein it is risky for us to do the surgery, then also we go for a closed reduction. So but the disadvantage is that the nutrition is compromised, because in the closed reduction you are going to fix the teeth. The person will not be able to eat anything. So the person is going to be on a liquid diet for like 4 to 6 weeks of time. So the nutrition is compromised, and since the teeth are fixed, the person will not be able to even talk. So the speech is also compromised. He cannot go out in like in the people. So the social inconvenience and the airway compromise, because all the time the teeth are closed, loss of function, all these things are which we see in the closed reduction. Open reduction is you do not have to do any compromise. So we do the surgery, we fix the plates, and that's the done. So after you fix the fracture segments with a plate or screws, then we remove the intermaxillary fixation. Now guys, you have to picturize it. A person comes to your emergency department or to your clinic with a fracture, and you are the only oral surgeon out there, or you are the only doctor. First of all, you need to see airway, breathing and circulation is maintained. And if you see that all the three things, emergency, there is no emergency situation, and in that case guys, you can go for the closed reduction. But if you have to go for a surgery, say in an emergency surgery, in emergency surgery only, after you have treated the emergency in the operation theatre, you are going to reduce the fracture segments together, and then you are going to fix the maxillary and mandibular teeth, so that when you are doing the reduction, there is no movement which takes place, because once the person opens the mouth, again the fracture segments will get displaced. So we do not want this to happen. So what we do is, if you are doing plates or screws, if you are placing in the fracture segments, if you are doing the open reduction, then before surgery you do the intermaxillary fixation, and after you have placed screws or plates, then you cut all these wires, and then the person can, when the person is discharged, there is no intermaxillary fixation. The person can eat or drink nicely. So nothing is compromised in open reduction. But the problem is that there is a surgery which is involved. So there is anatomic reduction because we are looking at the site and we are reducing it. So, and the fixation in the desired position we get, and also there is no functional compromisation, no nutritional compromisation, but the disadvantage is that it is involved with the surgical procedure. So there are every complication of surgery. So that again can be, there is no complication as of, but there can be complication involved with the surgery, and if the person is medically compromised, then we get in big trouble. So this is the differences between the open reduction and the closed reduction. Now that you know, if the fracture is in its position, if it is not displaced, then we can think of going for the closed reduction. But if in that case also the person wants to go for open reduction, we go do the surgery and then we put the plates and all. But most of the times we have to go for the open reduction in case of a maxillofacial trauma, say in case of a face trauma, a leaf fracture or any fracture. Most of the time these fractures happens after the injury, after like accidents. So most of the times we have to go for the open reduction. But when you are doing the open reduction, so before surgery also you have to do the intermaxillary fixation. You have to fix the maxillary teeth to the mandibular teeth. So guys, let's talk about the intermaxillary fixation. Now, if you are doing a closed reduction, then you need to go for intermaxillary fixation for like 4 to 6 weeks, and during that time the person is on the Ryle's tube, or you are like placing a straw so that the person can drink on at least on the liquid diet. So what are the indication and the contraindications of intermaxillary fixation? Where can we use, where can we not use? So in case if there is a non-displaced fracture, right? Fracture is not displaced, we can go for intermaxillary fixation, and this is a kind of closed reduction procedure. Or in case where there is a grossly comminuted fracture. So fractures we will be talking about after we cover the principles and basic. But let me tell you, comminuted fracture is a kind of fracture wherein, say suppose this was the bone. Now after the fracture, what happens? There is a fracture. Now this bone is into like small pieces. This is a kind of a comminuted fracture. So what you do, if you open this site up, so the bone fragments, all the fragments will be lost. So we cannot open it because the bone is already into so many pieces. It is going to be very hard for us to handle this situation. So in that case, when the bone is broken into small pieces, we try to avoid, or we do not go for the open reduction, we go for the closed reduction. So if in case there is a grossly comminuted fracture, we go for intermaxillary fixation and the closed reduction. Or in case fracture in the children, or in case guys edentulous atrophic mandible, because atrophic mandible, guys, because what happens if the person is edentulous and the mandible height is very less, then we go for the intermaxillary fixation and the closed reduction. When we do not go for intermaxillary fixation, when there is a history of seizures, because the person will be in a closed mouth state for a long period of time. That's the reason we do not go for. Or if in case if there is a compromise in the pulmonary function, then also we do not go for the intermaxillary fixation. Or in case if there are GI disorders, because nutrition is going to get compromised, right? In all these cases, we do not go for the intermaxillary fixation. Intermaxillary fixation, we will be covering the direct interdental wiring, so guys, direct interdental wiring is passing this wire through the teeth, maxillary teeth, and passing the wire through the mandibular teeth. So what do we do here? Say suppose this is a tooth, then we take the wire, we pass through the wire all around the teeth, then we twist this wire. So like this you twist this wire, and you do this for maxilla, you do this for mandible, and then both of these ends, this end and say this end, we both of these end also again we twist it. So this is the direct interdental wiring. So that means twisting the maxillary teeth, the mandibular teeth, and then again both of these twisting together, get the patient in the centric relation occlusion and then fix it together. So next one we have is the indirect interdental wiring. So indirect interdental wiring is making a IV loop. Indirect. And if you want to see the demonstration of all these wiring, then you can check out the intermaxillary fixation with interdental wiring video in the playlist in the oral surgery series. So indirect interdental wiring. Indirect interdental wiring, we make a loop, and in the loop then we place this wire. So if you can see here, these are the loops. We call the IV loops in indirect interdental wiring. Next one we have is the continuous or multiple loop. So in continuous or multiple loop wiring, we make these loops continuous. So these IV loops are continuous in case of continuous or multiple loops. If you can see here, these are the continuous loops, right? So and then we wire both of these maxillary and mandibular together then later on. So this is the continuous or multiple, wherein we are going to continuously make the loop and then pass the wire through the loop, and then both the maxillary and mandibular teeth getting in occlusion and then fix it. Next one we have are the arch bars. So arch bars are the bar. If you can see here in the maxillary teeth, see we are taking a side profile, guys. In the maxillary teeth, they are facing upwards like this. And in the mandibular teeth, they are facing downwards, so that either you can put the wire or you can put elastics, any of it. So what you do, you take a wire or the elastic and then you close them together using these bars. As you can see over in the diagram, these are the arch bars, and the wire is passed through these bars and then they are fixed together. Then guys, we also have in the diagram over here the cap splints. So these are like caps, but they are doing the purpose of splinting. So if you can see here, these are the cap splints and these are used in the children. Then we have the gunning splints. So as you can see here, these are used in the edentulous patient. Gunning splints. So here the wire is passed across all these. So all these are the gunning splints used for edentulous patient. Patients. We also have pin fixation, wherein we are going to fix the segments with the pins. So this is pin fixation. And guys, if you want to watch the demonstration of all these wirings, interdental wiring, all these wiring, you can watch the video of intermaxillary fixation with the interdental wiring, which is there in the oral surgery lecture series, which you will find in the playlist of our channel. So guys, this finishes the open close reduction and intermaxillary fixation. Next video lecture we will be talking about the internal fixation. So all the principles of internal fixation we will be covering in the next video lecture. I hope that you have enjoyed this video lecture. If you have enjoyed it, give it a thumbs up. Also comment in the comment section below, because this motivates me to put more videos for you guys every day and to make free notes for you guys. So can support me on Paytm as well as on PayPal to make free videos. So till then, keep reading, keep learning, stay motivated. I'll see you soon in the next lecture.